Hi, this video is going to be on acquired color vision anomalies. Okay, so we already looked at the congenital color vision anomalies and the characteristics and also the types. So now we're gonna move on to the acquired color vision anomalies. So acquired color vision anomalies of color vision are secondary to disease or toxicity, as I've been repeating many times on this. They may be either red or green, or blue yellow in nature. Okay, so this when it comes to this and acquired color vision anomalies, it can be unilateral or asymmetric. So it can be differ in terms of severity for right eye and left eye. Okay, because acquired anomalies may be asymmetric, it is important to perform color vision tests monocularly when screening for these conditions. So depending, if let's say you have a patient that comes into your clinic or practice, and then they have some complaints, when you ask about color vision related complaints and all that, if let's say they mention recently only I start having color vision anomalies, before that I don't have anything, or they say that, people start commenting on my, when I name colors, people start commenting on me and saying that it is wrong or right. Okay, sometimes wrong, sometimes it's right. So if let's say patient comes in with that kind of complaint, you have to do color vision test. Any color vision test that you have in your practice, you have to do it monocularly. If let's say a patient comes into your clinic complaining that oh, I have some defects since young, I always make mistake with colors, then with that patient you do binocular color vision test. If let's say a patient comes in not knowing that they are having any color vision defect and no complaint so far, you can proceed with binocular color vision test. Okay, so if let's say patient come with a recent complaint, then only you attempt a monocular color vision testing. Otherwise, it's binocular all the time. So if a patient with a unilateral anomaly is tested binocularly, the result may be normal, reflecting the performance of the unaffected eye. Okay, this is the reason why you have to do a monocular testing for patients who have recent complaints. Because when you actually mistakenly have actually conducted the test, binocularly, what will happen is the unaffected eye will make the right choice. Okay, make the correct, answers, or make the correct option right. So that will actually, blind the actual result of that particular patient. So the test should be first administered monocularly to the eye most likely to harbor disease. Like for example, if let's say patient say, I have cataract, I was, during history taking, if let's say you ask patient, have you done your eye checkup before? Yeah, 1 year ago. And then the doctor told me that my right eye is having cataract. Okay. So if let's say that is the case, right? So you start with the right eye, testing on the right eye first, because you already know there is some cataract on the right eye. Okay. Or after you measure the VA, if let's say patient never complained anything, but after you measure the VA, okay, you found that the right eye is the worst eye. Then you start with the right eye first. When you want to actually perform the color vision test. Okay, so that is the some criteria of acquired color vision anomalies. Now we move on to Callner's rule. Okay, according to Callner's rule, okay, basically this Callner have actually conducted a research where this Callner is actually, gathered patients with different ocular conditions, like for example, nuclear sclerosis, AMD, someone with diabetic retinopathy, Leber's optic atrophy, toxic amblyopia, and lesion. So he actually invited all these patients to his clinic. And then what he did is he performed color vision tests. And then after he performed all the color vision tests, and then he analyzed the data, he found that patients who are actually having media-related problems like nuclear sclerosis, cataract, and all that, they are prone to have blue-yellow defects. So most of his patients who are having nuclear sclerosis, okay, when they actually performed the color vision test, it was found that they are having blue-yellow defect. While patients who are actually having ARMD or diabetic retinopathy, whoever had the problem related to outer retina also having blue-yellow defect. But when he actually performed color vision test on patients who are having Leber's optic atrophy and toxic amblyopia, they have actually the layers that damages the layers in the inner retina. It was found that they have red-green defect. The same applies for someone who's actually having some lesions in pathway, also prone to have red-green defect. So he actually, came out with a rule that, okay, this can be a guideline. Okay, if let's say a patient comes in with, complaints and then, but they are not diagnosed before. But when you do a screening test, because in entrance test, we do perform this color vision test, right? Okay, if let's say the patient has no complaint, but then when you perform the Ishihara plates, they fail the red-green defect. They were found to be, they fail Ishihara. So definitely they're going to have red-green defect. So if let's say they have red-green defect, this patient is possible to have these three, diagnosis. You can list down the differential diagnosis at these three. Okay. So this one is not a proper guideline, or it is not like a definite diagnosis, but is just, put this in the pathway to actually, for the diagnosis. Okay, so this can be like a guideline, for you to do further assessment later, okay, to find out whether this patient is having any other ocular conditions or not, other than what is reported by the patient. Okay. So when a patient who's having acquired color vision anomalies, okay, you have to perform monocularly. That is the first rule. Perform monocular color vision test. Any test that you want to perform, let's say they come with a recent complaint, you have to perform monocularly. Next, after you perform the test, okay, if let's say you have the finding, that finding can be actually, give you a clue that what kind of ocular condition that this patient possible to have. If let's say elderly patient coming to your clinic in geriatric, like 80, 90 plus, so that patients are, they prone to have all these, ocular conditions. So that can be like a lead to the further investigation that you want to perform on this patient. So that will be in detail about, acquired color vision anomalies. Okay, now we move on to the next one. Okay, another color vision deficiency, which is known to be achromatopsia. Okay, so achromatopsia, it's a rare condition, okay, where the patient manifests monochromatic or nearly monochromatic vision. Okay, so this is, it is not because it is something like congenital also, but this is a very rare case. Okay, even till now, I have been practicing for almost like about 13 years. I've never seen anyone, I've never encountered anyone with achromatopsia. Okay, so it's a rare condition. So it is a most common in autosomal recessive. The most common is the autosomal recessive achromatopsia. Okay, and they are further divided into two. So it is not, it is the chromosome for this gene is actually at the, not at the sex, not in the sex-linked gene. So that's why it is very rare. Okay, so they have two types of achromatopsia. One is complete, another one is incomplete. Complete means where they only have rods only. They don't have existence of cones in their retina. Okay, while incomplete achromatopsia is they have some cones, residuals, saki-baki of long and medium wavelength sensitive cones. Okay, and what kind of problem that this patient would have? The sign and symptoms only would be one, no or very poor color discrimination, obviously with the rods, okay, or minimal existence or presence of green and red cones, only give like a very minimal color discrimination. And the next one, patient would have nystagmus. okay, and photophobia, because there is no cone to actually absorb excessive light. There's no photoreceptors. And their visual acuity, as I mentioned, cones are responsible for detail seeing. So without cone, obviously the visual acuity is approximately 6/60 only. Okay. So basically, this patient, how can we help them? Okay. So dark red lenses, which minimize the bleaching of rhodopsin, thereby permitting rod function under brighter lighting condition, can be recommended for this patient. Okay. Again, when it comes to these tinted lenses, all it very much dependent on the patient. Okay. If let's say they're comfortable, then only we're able to prescribe. There are a lot of guidelines saying that this amber light tinted lenses is good for this. This color tinted lenses is good for that. There are many guidelines that is provided by the supplier, but the one who is actually practicing that by prescribing will have a better idea. Like people like you, I'm very sure with all these years of experience, you have a better idea, based on what you see when you prescribe by yourself. I totally agree with, with the idea that when you want to prescribe all these tinted lenses and all that, it's a try and error thing. If it works, it works. Okay, it doesn't apply to everybody. Okay, so the same for these dark red lenses also. If let's say a patient as such, okay, that comes to your practice, you have to try this first rather than straight away, confidently saying that, oh, this is definitely going to work. No, you have to try that first and see whether patient is happy with that, patient is comfortable with that, then only you prescribe. And how these dark red lenses happens is how our cones and rod function is, okay, when we are in a bright area, okay, it can be under, it's a daytime, or it can be in a room with the lighted rooms and all that, our cones will actually get activated while our rods will be bleached and then get deactivated. Okay, so deactivated. So that is the reason why you're able to see details all in the bright room. But what happens is, if let's say switch off the light, or the day actually become night already, very dark. So what will happen is the cones will actually, lose their sensitivity, and the rods will actually take charge. Okay, that is the reason why if you go to, if let's say when you want to go bed, right, when you switch off the light, the first few minutes, right, you won't be able to see anything. You feel the room is, super dark. Okay, but after a few minutes, you will see more things in the room, because that's a time when you off the light, right, the rod is not activated yet. So once it activated, then you are able to see things better. Okay, so that's how these dark lenses, this is where these dark red lenses is going to be, it's going to be helping this acrothermopsia people. So this acrothermopsia patient, the problem that they will be having is, okay, if let's say, obviously night will come, and when night, they also have to survive at daytime. Okay, nighttime is not an issue because they have rods. So once they switch off the light or dim the room, it will get activated, okay, straight away. But in daytime, they will actually get deactivated. Okay, so we have to activate the rods, because there's the only way that they're able to see things. If let's say it's not getting activated, right, it will be black, okay, for the patient. So this dark red lenses is actually minimize the light that goes into the eye, which, induce the bleaching of the rods and deactivating them. So when there is a little amount of light goes into the eye, so the rod will think that, oh, it's already night. So I have to get activated, and I have to be, opening my eyes to see the details in front of me. So that is a signal that is actually, that is getting induced with these dark red lenses. Okay. So the next one is cone monochromasis. Cone monochromasis is an exceedingly rare case. This is another rare case. If you say achromatopsia is a rare case, cone monochromasis is also another rare case, in terms of color vision deficiency. So cone monochromacy is an exceedingly rare disorder in which visual acuity is normal, yet the patient manifests monochromatic color matching. Okay. So these patients only sensitive to one particular light color. Okay, but otherwise their VA is good. Okay, there's something is wrong with the photoreceptor only, but the cone is actually functioning properly. So although this condition is too rare to have extensively studied, it appears to involve a defect in post-receptor processing or color information. Obviously, if let's say the cone can only detect one color, there's definitely a big confusion when information are passed to the brain. Okay, so that is achromatopsia and also the acquired color vision defect. Now we move on to chromatopsias. So what is chromatopsias? Okay, it's not a true color vision deficiency because they do not typically produce a decreased ability to discriminate colors. Okay, rather they represent a distortion of color vision similar to looking through a colored filters. So basically this chromatopsia is not a true color vision defect. For example, if let's say you're trying one tinted lens in front of both your eyes, okay, you will see the color discrimination will be affected for you. You can, I'm sure you have experienced that colors would appear differently for you. But once you remove the filter, your color vision is back to normal. So the same thing happens for ocular condition also. For example, if let's say a patient is having cataract, so it works like a filter, that I explained just now. Look, it will work like a filter where the discrimination of colors is getting affected. But once the cataract is removed, their color vision will be back to normal because their cones is still functioning normally. It's only something is blocking in front of the eye. That is chromatopsia. It's not the true color vision defect. But if let's say you stay without removing the cataract, you will be having color vision deficiency until you get it removed. Okay, if let's say lifelong, you're not going to remove the color vision, cataract, you will be living with the color vision deficiency for life. So patient report that objects have a color tinge or halo. Okay, like chromatopsia may follow cataract extraction. For example, a nuclear cataract acts as a yellow filter. Okay, and they absorb this blue light. Okay, when you wear yellow filter, it is expected to absorb a blue light. Okay, so the patient has experienced this yellow filter. Okay, where the imagine if you wear a yellow filter in front of you, you just put in a yellow filter in front of your eye, you will see things different. Okay, especially colors. Okay, if let's say you have been living with that for about 5-6 years, you would kind of it would be like a habit for you because you have been seeing colors differently. Yeah. So upon removal of the cataract exposes the retina considerably more blue light compared to when a patient had the yellow light. The yellow filter. Okay, then it was experienced in some time, resulting in the perception of blueness. So whatever they see with the cataract, right, they'll see all things looks bluish. Okay, but once the cataract, when patient is having cataract, the yellow filter makes the perception of color to be different. But once they already remove the cataract, what will happen is more blue light goes into the retina because there's no more cataract as working as a filter. So what will happen is they will see things very bluish, okay, because a lot of blue light goes into the eye. Okay, so as the visual system adapts to the new distribution of radiant energy, the effect wanes off. So you don't need to do anything, no need to take medication or no need to do any surgeries to overcome this. Okay, so this chromatopsia is like, only for temporary, a temporary defect. And these chromatopsias can occur secondary to various medications. For example, digitalists may produce xanthopsia because they look at this, digital devices which is, emitting blue rays. Okay, so they will have this xanthopsia. Okay, fluorescent used in fluorescent angiography can also provide xanthopsia. So these are the conditions, okay, where you experience this chromatopsia, a short term of color vision deficiencies. Okay, so we already looked at the acquired color vision deficiency, how they actually work, and also we looked at the Callner's rule, how that can be a simple guideline, to do further investigation based on the findings that we get. And also we looked at the chromatopsia and achromatopsia. Okay, achromatopsia means, they only live with rods, while chromatopsia is not the true color vision deficiency that a person would have. So that's for the lecture for this particular portion. Thank you.